the world's not really black and white. It's just very gray.
Yeah.
And what people suggest and what they do, sometimes is not always the best therapy, but sometimes it works really well.
Yeah.
But one needs to question things. That's the first thing. And to find out what the best evidence is.
Yeah.
And then to realize that what we know is the best evidence doesn't always work exactly in individual patients.
Mm-hmm.
So it's to work through those things and to find out what works best for your pet. That's essentially what it is, and it's about finding that right combination. And at the end of the day, I think us as professionals, we sell one thing, and that's trust. We actually sell a trust relationship, and it's building that trust relationship is absolutely vital. And I've had clients come and see me, ask me for my advice. I've had discussions with them and everything else like that. And it's about them either trusting my advice or not. And some of them, my advice to them is to find a practitioner whom they have absolute faith in, because that, first of all, by the way, makes the therapy far more likely to work.
Yeah.
But that works for an entirely different reason. But they're going to follow a journey now for months to years. And it's important that whoever they're going to follow that journey with, that they have a really good relationship with them, because there's going to be good and easy times, and there's going to be some tough times that it is there. And it's often in those tough times, people start to seek multiple opinions. And as I say, the more opinions you seek, the more confused you're going to become, because everybody will approach things differently. And that building that trust relationship is so important to do it. And sometimes, by the way, these trust relationships with the clients don't lie directly with me. They rely for example, the physiotherapist or their general practitioner. Some of them have it with me, which is fine, and some of them have it with other things. So then I become more of a consultant in the whole thing. I'll talk to the general practitioner or their physiotherapist, and we work together and manage it as a team. And I think that's how these patients need to be managed. They need to be managed as a team. But it is about building that trust relationships. So if you ever want to go to a horrible website, one of them, you can go to metacamkills.com. That's out there. It's all about cats who die of renal failure. That's out there. And I've had one client with a cat with renal disease. Now, a cat has renal disease and osteoarthritis. And there's actually quite a few observational studies all out of Australia, which are really good to show that cats that were on Metacam at a really low dose, it's about just less than 0.05 milligrams a kilo, there was no progression in their renal disease. As I say, it's not absolutely true science. There was no progression in their renal disease. It didn't affect how long they lived, but it improved the cat's qualities of life.
Yeah.
And now you have a cat in renal disease, and I say, let's try it on some Metacam. And this lady has unfortunately been to the metacamkills.com website and said, no, I'm not giving my cat Metacam or any non-steroidal because it's going to kill its kidneys. And you land up that, and it becomes actually quite difficult to get that trust relationship going. And building trust relationships is absolutely important. By the way, there's also remedialdeath.com. All the non-steroidals have a hate website if people want to go search for them. They're all out there. That it is there, but it's about building that trust relation to say, look, I don't think it'll do your cat any harm. These are the benefits. Let's give it, let's watch creatinine and urine SG, for example. And those have been studied in those studies, and their urine SGs didn't change, their creatinines didn't rise. The interesting thing is that they selected a control population, so they just matched cats out of their thing, because it's all retrospective. So they took all their cats with renal disease that they gave Metacam and matched them sort of for the same age, gender, breed, all the other facts for cats who didn't receive Metacam. And their renal disease actually progressed.
Yeah.
And part of that theory is that part of cats' renal disease is that it's an inflammatory disease of the kidneys. So giving a non-steroidal suppressed inflammation in the kidneys, and that's why these cats who received its disease didn't progress. As I say, it's not absolutely perfect science, but there's reasonable evidence to say this is something that we could use. And then you just land up. So it's about finding that trust relationship. To me is so important for clients to do, is to find the person, as I say, it's that gatekeeper of drugs, and then becomes the key person, if I can call it, in the therapy of that animal, that they sort of the people who control a lot of the therapy, and we all put our roles into it. There's one person I've always wanted to get on my team, and that's a psychologist, because I think some of the patients I've treated with chronic pain, I could never help the client. If I look at, for example, some of my dogs with cancer, for example, where they've been through with their own loved ones have had cancer, etc. Their dog now has cancer, and they're not coping with it. And I always feel very inadequate in those situations. But not only that, is, as I said to you, like, we start off with a disease which we can't cure, and we're going to manage this for a long time. And I think there's important roles to these type of aspects as well with the owners. Part of the thing is to keep them motivated as well, and keep them in tune with what's happening. And I think that's actually quite an important component. But as I say, to have a multifactorial team actually becomes really useful. And if you all work together regularly, you also understand everybody's own little idiosyncrasies and what they like and what they hate. That it is just I mean, I work in a number of practices. So I work with a surgeon, for example, who doesn't believe in glucosamine and chondroitin sulfate. And as I say, I could support his argument or argue against him with it. But he's not keen to use it in his patients, for example. And I know that in advance. And I can tell the clients, you know, he won't recommend these for these reasons. And you know, he's quite justified in it. This is why I think they work. But you can certainly do that.
You touched upon the psychology side of things, and we've got a group of people who work and volunteer for CAM, excuse me, called the CAM ambassadors, and we've recently just done a little bit of just very quick in-house training on anticipatory grief, and that's kind of what you touched on, the being given a diagnosis and almost starting that grieving process before the pet has died, and how difficult that is, and how hard it is for owners to go through that and need the support. And I think you've touched on it there. And one of the interesting things we found from all our reading, and Gwen Covey-Crump's written a little article on it, was that peer support was really important too. So we're lucky in that our thing is arthritis, and we run Holly's Army, which is like a forum for owners to come and chat about you know, that they've had their pet diagnosed or making a really difficult decision, or my vet said, can I try this drug, who's had experience of it, and just getting a little bit of experience, because I think that is one thing as vet professionals we can't provide. We have that white coat effect, don't we? We can tell them all the facts and figures and what we would do and what we'd want to do, but sometimes they just need some emotional reassurance, and that's, we try our best to do that, but it's difficult to do that and be the clinician at the same time, I think.
Yeah, and I think, you know, that's one of the challenges of client communication that is there. Different people actually want to know different information, and to read people is sometimes quite difficult. Sometimes people just want to know the warm and fuzzy about, oh, I give this, going to make my animal happy. Sometimes some people want to know all the detail, for example. And some of those clients who do want to know the detail, it's even, I have the luxury of a lot of time. I don't always have the time. And then I will email them the journal articles, for example, or the evidence, and they can read it in their own time and then send me back questions as they've read it, or questions that they have out of that evidence. And also adjusting to what people's needs of information is actually quite a challenge for us. It's about reading people. What do they actually want to hear from me? That's the one thing. And I think from our side as well, we make judgments for clients often in therapy, and there's the ancient Greek philosophy of the doctor knows best. So I don't know what your interactions are with your doctor, but often you'll go and say, I have this, or whatever. You'll diagnose something and say, oh, you got a cold. I recommend you take this, write you out a prescription, and off you go. And that's basically what happens. So in other words, the doctor doesn't consult too much on your therapy, if I can put it to you that way. And sometimes in veterinary medicine, we've landed up at the opposite end of the scale, where we'll go and say, oh, this is what's wrong with your dog. Now, we could give it A, B, C, D, E, F, G, H, R. These are your options. You can add surgery onto it. If you look at osteoarthritis, things like that, you can do cruciate ligament surgery. So you can do an extracapsular repair, or you can change the joint angle. You can do a tibial crest advancement, and you go through these lists. And some people say, oh, look, your dog's got cruciate ligament. It gets a TPLO, has whatever the non-steroidals, and you do it. And so there's these two different philosophies that play. And one depends on personality type and perhaps when you're trained about those things. And my question is that some clients actually don't want the responsibility of making these decisions, and it's important to realize that. And I know there's a whole lot of legalities and a whole lot of other things about it. About reading clients from what information they want is also important. Some clients want to know, I'm going to give this, and that's what I need to do. Other clients want to participate in that discussion about what happens and what is there. And the really tough choices is sometimes, do you make a recommendation of therapy? If you start to look through people, for example, what owners want to know is that they've done everything that was possible or that was in the best interests of their pet, especially when it comes to making end-of-life decisions, for example, that they've done everything that was reasonably possible.
Yeah.
And I'm just going to use dialysis as an example because it's something that I do on the ICU side of it. But you get cats, for example, in chronic renal failure that are there, and the owners come and ask, can't you do dialysis? Well, the answer is yes, you can do dialysis. Yeah. The question is this actually a solution for the patient? And it's often vets who have suggested, because the owner said, well, what else could I do now? And if you've got chronic renal failure, dialysis then is an everyday or every second day affair, depending on whether you're doing peritoneal or extracorporeal type dialysis. But it actually has significant impacts on lifestyle and long-term effects. And in humans, for example, it's fun. I can dialyze you and hopefully somebody will do something stupid and we can transplant a kidney into you. Yeah. If we're not going to do a kidney transplant in the cat, there's no point in starting this because your quality of life, and even we know that in humans, deteriorates on dialysis. Yeah. It actually becomes a more serious discussion about saying, where's the journey and where are we going to? And sometimes some of the things we suggest is not always appropriate, and it's how do you edit? And then you'll get told by some of the people, no, you've got to tell the owners everything that's possible. I often think that we should work with what everything is reasonable for that patient, for example. You know, a young two-year-old, I'll just use a Labrador, for example, coming in with hip dysplasia, or a 16-year-old Labrador coming in with hip dysplasia, to me, follow potentially two different pathways of therapy. Yeah. You know, if it's a 6-month-old dog, we're going to start looking at doing TPL, triple pelvic osteotomies, or something like that if it's very much younger, for example. Yeah. But sometimes, like the courses we follow, is that not everything is actually an option for those patients. And working out what's the right option for patients is challenging. It's not always that blanket approach, which, this is what's wrong, this is the course you follow. Yeah. And I think it's that type of thought, and that's why that trust relationship is so important to say, in your dog, I think this is the best therapy. And some owners, by the way, want us to make that decision because they don't want to make us make that decision at all. Yeah. And Ohio State University, by the way, has a really nice paper for sort of working out end-of-life care and quality of life towards the end of life. And I often give it to clients. I don't give it to a client who walks in there with their 2-year-old dog. I give it to the client who walks in there with their 16-year-old Maltese poodle to go through, for example, to have a look at it, that it is. Because a 2-year-old dog, people don't want to consider that, especially not on the first consult. Whereas on a dog that's a lot older, there's a lot of other things we're going to talk through and talk to the owners about, things that are happening. And I think, as I say, that's all part of that trust thing that they build it up. And the other thing is, when we work as teams, is to be consistent with our messages as well. Because, as I say, they may see you, they may see a physiotherapist, they see an acupuncturist, in my case as well, are these people, and then everybody has these divergent opinions. Yeah. And that's often when distrust develops, which is bad for patients. You know, they've shown in medicine, even if you do a therapy which is not the ideal, optimal, or best therapy, but it's consistent, patients do far better than just changing therapy all the time. So it's important to actually get that consistency for the patient. And as I say, that's all built up in that trust relationship. Follow the person and keep going for it, you know.
Yeah, I think that's so true and so important to work as a team. We talk about it all the time on CAM, multimodal approach, but I mean, we can't hammer it in enough, honestly, but yeah, we think it's so important. You work with your vet, you work with your physio, you work with your hydrotherapist, acupuncturist, you work with, you know, maybe you're not getting enough from your vet, maybe you need to ask for a referral to somebody like you who runs a specialist pain clinic, and is a bit more expert in drugs or whatever it may be. And I think that's like really, really important to have that approach from multiple professionals, but who are working as a team, not as lots of individuals all trying to change and shift what the overall plan is for that patient. Yeah, tricky though.
No, yeah. Oh no, it is. It's very tricky to do all of that. Juggling things is sometimes quite difficult. That it is there.
Yeah.
That it is. But as I say, it's about drawing those lines and actually what is the best for that patient. And as I say, everybody agreeing to what is there.
Yeah.
That it is. And as I say, then there's always that toughness of making what's a fair decision for the patient.
Yeah.
And I think that's another conflict that we often get drawn between, is what we think is fair for the patient and what we think is fair for the owner. And the two of them are not always the same thing, but we create that conflict ourselves because we think about it, sure, if this was our dog, I would do this. And I've had these dogs. That's why I wanted a psychologist on my team. This was her mother's dog. Her mother is now passed on. This is the last physical representation or association that she has with her mother.
Yeah.
And that's what's represented in that dog. Yeah, it's reaching the end of its life, but now you've got to try and make it keep going forever, if I can put it to you that way, because of the owner's attachment to them, which is not possible. And as I say, those type of things create conflicts us where we say, sure, right, let's try this or let's try that, because it's a tough thing to say, no, I think you should put your dog down. And the owners don't want to hear that. So sometimes we ourselves start to make those choices and say, oh, I don't think they want to hear this. And those are the tough discussions to actually have with the owner. And that's sometimes, like, I always approach and I start with saying, what do you want me to do? What would you like out of this whole consult today? And you know that upfront, oh, I want my dog to be pain-free and live forever. Yeah. And then, you can start to say, well, I can't do that.
Yeah.
I really cannot do that for you. What we can try and do is improve quality of life. This is a point. And to ask them about points where they would call it quits for suffering, to start to get them to look at it. And I often ask them to go and ask friends, family, people who visit them, for example, about end of life. Go and have a look at go and get what your friends think about Fluffy. Ask them their opinion about how badly it's suffering. Because often, if you live with an animal all the time, you don't notice these small declines and you get used to it. It's very happy. You get used to, it's been doing this, and no, this is fine. Your friends will come around and say, hey, but this is not acceptable.
Yeah. And when you're talking about like a Labrador, for example, if I hear owners say, well, the day he doesn't want to eat is the day, we call it. Well, you might have a Labrador who's not walking, can't toilet for itself, you'll still eat its food because it's a Labrador. So, it's difficult, isn't it? Because you do need to have some lines, and not just like one specific line, but maybe if this and this is happening, or if there's more than one thing, I don't know, we have a good day, bad day list on CAM, and if you're having a lot of bad days and those good days are just not there, you can really visually see that. And I think you do that with the your quality of life scales and things like that. It's having sort of objective assessments sometimes to take the emotional side of it out, because I know as a clinician, I'm a massive soft touch, so especially with the patients that I would say palliatively caring for, I'll be seeing them every week, every 2 weeks, for it could be months, it could be a year, and I bond to them. And I always say, when we're getting to the point about really talking about what is fair and what's quality of life, that's maybe a point where maybe you need to go and see your vet. At this point, I'm just your acupuncturist, and I'm here to keep them comfortable at the moment, but maybe we need to go and get a fresh pair of eyes on it, because sometimes I'm a bit too close to the situation and find it a little bit difficult to get that distance. And I know all the family things that are going on, and you know, that I love the dog at this point. I've got a real bond with the dog, and I want, you know, I don't want to lose the dog either. And it's hard sometimes to get that distance, and you do really feel for the owners. And then having those objective assessments there to fall back on, you can make sure you're clear what is actually happening. And you are biased. I mean, as a therapist, I want my therapy to work. So I'm sure there's times where I'm believing it's working more than it is working, because I truly want it to work. So, and if the owner truly wants to as well, so then you've got owner bias, my bias, you know, it's tricky, isn't it?
Oh no, it's always going to be like that. Well, you see, this is the sad part to what we do. Even our pain scores, it's us to do it. Animals don't do the pain scores. It's people who do it. And so bias will naturally try and creep into these type of things, because we give something and we want to know that what we're doing is working, that it is. And perhaps having that belief helps a lot to see it. But it is important to get objectives. You're talking about more days than bad days. That HHH MMM score does that. You have more days than bad days. It's one of the parameters that they evaluate. So it's to get people to start to think along those lines, especially as dogs get a lot older. Yeah. That's going along, is to think about well-being, health, hydration, eating, urinating, defecating, etc., being painful, and working out that score. So that score is very useful because it gives you an objective way of looking at it, and certainly say that you're getting close. And if you know, even if you have emotional interests involved in it, you can still be quite objective with some of those scoring systems, because you can see where the trend is going. You'll know it's going down, and that score, for example, if it's below 35, they recommend euthanasia. The maximum score is 70, but you'll notice it's going 60, 50, 40, and then you'll start to make it like 38, 37, 36. You know, you can see that type of thing, because you just don't want to put it below that number. But you look at the trend of what is happening objectively, and you can say, cool, we're hitting that point that is there, that it is. And owners need to feel comfortable about that decision as well. And I think when it comes to end of life care, I never say to owners, you have to euthanize your dog now. I never tell them that. It's time to consider doing it. My job is to make your dog as comfortable. And as you get closer to the end of life care, if I can put it to you, often a lot of the interventions we do will shorten lifespan just in its own necessity, if I can put it to you that way. So if you look at cancer patients, for example, giving them higher doses of opioids, we know shortens their lifespan, for example, but it keeps them comfortable. We're lucky in that our patients don't have to die of their diseases. We can call it quits earlier so that they don't have to suffer through the last bits and pieces. But what you spoke about earlier is about getting people to start that grieving process. And it's the one thing we're lucky about, is that we give owners the opportunity to do it if we can give them the tools as well. At the same time, to start that grieving process as well, to do the last things that they want to do with their pet, whilst it can still do it. And we often, as they say, our greatest regret on our deathbed is not what we did do, it's what we didn't do. And to say to people, like, you know, this is not going to last. We're going through a really good spell. Do the stuff you want to do with your pet. You know, this is your opportunity. Take advantage of it. That it is there. And I think we often don't do it. But then I think us as a Western society don't always embrace death very well.
Yeah.
That's a whole different debate. But we don't do it. And we see it as a negative thing. And I think many veterinarians see euthanasia as a negative thing. But it's actually a gift we have compared to human medicine, where we have to wait for people to die even if they're suffering. We actually have a gift that we can use as an important tool to limit suffering when required. That it is, yes, sometimes, as I said, there's a whole lot of healthy animals, unfortunately, who sadly get put down because they don't have homes. And so there's a sad side to what we do, but it's also a gift that we have. And it's about using that gift appropriately when it's required to reduce suffering. And I think that's an important thing to do that. And I think getting owners to realize that is important, to think about it. And, you know, going back into reflection, I ask people, what was your dog like when it was a puppy, you know, or its good years, and what did you do with it, and what is it doing now? And then you start to ask, well, what is its enjoyment in life and what is its quality like? And sometimes it'll take 2 or 3 discussions, 4 discussions to go through those things. And as I say, like if you give people a lot of information, they're going to listen to the first thing you say, the last thing you say, and the middle stuff they won't remember.
Yeah.
So leaving them with 1 or 2 important messages is important. And my first consultations are long, but after that, it's about picking the 1 or 2 things that you want to pick up and discuss with them. And if that's end of life care, then or getting to that point, then that's all we discuss that particular time. Besides perhaps some changes in management or things that I want to adjust, but it's to start to get that thought process, because if we go through tons of things, that becomes important. And just to put it in context, so they've studied this, for example, in people with leukemia. I forget which type of leukemia it is, but you essentially got a 5% chance of survival. When they discussed it with the patients who had the leukemia, the hematologists who managed them told them you've got a 5% chance of survival. And eventually they go and measure what their next of kin, either their wife or children, think they've got of survival. And that survival rate goes up to nearly 40%. So they think, the next of kin think you've got this leukemia and you've got a 40% chance of survival. And what actually happens is, in the process, people say, oh, and that 5% chance of survival, by the way, is with chemotherapy. And you say, oh, I've got chemotherapy, I can give it, you're now going to live. And that's what people read it as. And it's not always true. It's like saying, oh, I've got a non-steroidal, I've got an opioid, I can help manage your dog's pain with osteoarthritis. It's true, I can help manage that pain to some extent, but it's not necessarily a perfect solution. That it is there. And so how we have these discussions with owners is important. And that's why I say, look, these drugs can help your dog. Let's see how they help your dog. If we don't get any benefit out of trying this, there's no point in carrying on with it. We need to either find another plan or find something new to do. And if we can't get your dog comfortable, unfortunately, then we're going to have to make a tough decision. And I think then it would be reasonable to put it down. But it's important to make sure that the clients realize that they've done everything that is reasonable as well. In other words, and some of the patients, I'll see the clients come in and they say, oh, my vet recommended euthanasia. There's nothing we can do, because they weren't offered anything and they don't want to give up without trying something. And having that buy-in to have I tried something reasonable, and have I tried something and given it a reasonable chance to work, is also important. To say, cool, I've got this, let's see where we can get to. And I think that those discussions are important, but it's like when you throw all of this into one discussion, what people remember is actually very, very little. That's there.
It's overwhelming, isn't it? A lot of people, I suppose, haven't had their pets in these scenarios before, so it's we're throwing lots of things at them, drugs and physio and whatever it may be, and then talking about quality of life as well. And I think it can be just to the point where their brain physically can't take it all on board. And you probably, I don't know what the psychology is, but I imagine in those scenarios your brain will try and remember the positive things rather than the negative things. I don't know, but I can imagine that would be the case.
Yes, no, you do. And it's natural for us as people, by the way, to stick to things that give us hope. That's natural within a lot of our personality types. If somebody says, oh, this could work, there's always a chance that something can work, but it's how we phrase that, if you know what I mean. But often we'll think, oh, I'll give this, it's going to cure everything. And it's important to realize that that's not, and that's why I often don't refer to it as this will help, will make your dog's lameness go away, or any of those. Absolutely, yes. This is how we're going to manage your dog, and we're going to hopefully improve his quality of life. And we're going to see how his quality of life improves. If it doesn't, we got other choices, and I often will tell owners just some of the choices we have, just so that they realize, well, we've done all these steps, but this is not the end of the line. So I'm willing to go through these other steps. That it is. And, like I've had, for example, old dogs that is there. I think the one dog was about 18 years old, had bad hip dysplasia. And the owner said, well, I think we must do a hip replacement now, which is fine. You could do a hip replacement. And some people would have no hesitations of doing a hip replacement. The dog also has heart disease. And that was there at the time. And I said to them, but your dog, based on the other diseases are going on, doesn't have an expected lifespan of more than 6 months. They were quite horrified to realize. I said, we're going to do a hip replacement, and the rehabilitation can take you more than 6 months. So what do you want? Your dog to suffer and go through a whole lot of pain in its last few months? That's reality. If it's a 5-year-old dog, this is a different story. We're going to send it through some discomfort, rehabilitation, 6 months' time, it's doing really well, and it's going to live for another 5 or 8 or 10 years.
Yeah.
That's a different scenario to that other dog. And that's why I say, sometimes we can suggest things that are not always appropriate for a patient to take it out and to say, yes, but I don't think this is what's in the best interests of your dog.
Yeah, it comes down to that.
That is there. Sadly enough, the owners actually went in that case for the hip replacement, and actually the dog never walked again, but that's another story. And if they hadn't done the surgery, the dog would have still been around for a little bit longer. I'm pretty sure of that, that it is there. But I mean, it was a whole long complex thing. I mean, not that the surgery was a failure, but it had lost muscle mass. Its hindquarters were weak, a whole lot of things. And that's why it never walked. So that it only died about 2-3 months later after the whole thing. But if they'd never done it, they'd have still had a dog that could still potter around a little bit, and we could have managed its pain and got them ready for it, but it didn't need the surgery.
It's so difficult. That comes down to the just because we can doesn't mean we should, doesn't it? That's the mantra that we hear a lot.
Right.
Yeah, I think you're just so right there. And it's so hard, isn't it? It's so hard to assess that. And I think it's easy when you're the vet and you're looking in and you can see what you think, and you probably in this instance you knew what the future was going to be, and you verbalized that to them, but when it's your pet and you just want it there forever, you're so emotionally involved. It's really difficult. And I think it goes back to what you were saying about having really good communication and really good relationship, and having that gatekeeper that you go back to talk about these massive decisions with. And if they're saying, I don't think this is a good idea, that you've got the trust in them that they're saying that for your best interests. There's no negative reason why they wouldn't want you to do that.
It's a relationship we're going to build up that lasts from months to years with osteoarthritis. It's like a friendship. It's no different to a friendship or anything else like that. And that's the important thing. And also when the relationship starts to fall apart, like relationships happen and it releases that divorce point, if I can put it to you, it's important that you transition them onto somebody else whom they have a good relationship with. Give them the information that's there, why you've got to where you are, that it is there, and why your relationship broke down, or what you think caused the distrust, so that the next person is aware of that, that it is there, because it's for the patient's best interest that it is there. That it is. And like I have patients that I'm part of their management, but I'm not the manager, if I can put it to you that way. That there are other people, and I'm quite happy to be, like what they say, the second or third fiddle in the line. But I know where my place is and what my role is, so that's perfect. Sometimes I'm the first fiddle, sometimes I'm right at the other end of it. That it is there, but it's also working, and as I say, building that team or those groups that work together is vital, because it gives you the best outcomes for those patients. That is there.